Good day. I would like to welcome everyone to our session, the World Health Summit today, on essential surgery and trauma care. I am fortunate to be with my co-chair, Jeff Ibbotson. Jeff is the executive lead for the Global Surgery Foundation, hosted by the United Nations Institute for Training and Research. He's also the senior health advisor to the UNITAR program in health and development and has 25 years of experience in medical, humanitarian, and disaster relief. He is a trauma surgeon from Canada and is a fellow of both the Royal College of Physicians and Surgeons of Canada and the American College of Surgeons, and he will be co-chairing with me today. We also have 5 fantastic panelists and speakers. Now, first today, Jeff and I will be giving a very brief introduction, and then we will have the panelists speak for about 10 to 15 minutes each, and then we will have time for a Q&A. Jeff, at this point, I'll turn the mic over to you for several of your introductory slides.
Well, thank you, John, and a special thank you to our keynote speakers today for joining us. It's an honor for me to be moderating this session with you and having the opportunity to highlight this important topic. In 2008, Dr. Paul Farmer and Dr. Jim Kim stated that surgery may be thought of as the neglected stepchild of global public health. Despite many changes over the last 12 years since that publication, the need for providing safe, essential surgery and trauma care continues to grow. And it's with this in mind that it gives us great pleasure to feature this panel discussion at the World Health Summit today for the first time and highlight the need to focus on surgical and trauma priorities. An estimated 5 billion people do not have access to essential surgical care, including safe anesthesia, obstetric, and trauma care. This is despite almost 30% of the global burden of disease requiring a functional surgical care system for appropriate treatment. We know that the cost of meeting this need will be substantial. However, the cost of not acting will be far greater, with predicted losses in economic output of $12 trillion by the year 2030 if we don't take action now. The data of recent years has also shown us that building capacity in surgical care system not only saves lives, but is affordable and promotes economic growth. Furthermore, the COVID-19 pandemic has clearly shown the world the importance of countries having strong, resilient healthcare systems. We've seen that a strong surgical care, including safe anesthesia, can serve as the foundation of healthcare systems that can withstand emergencies such as the pandemic. Next slide, please. The remarkable change in the global burden of disease from communicable diseases to non-communicable diseases is well known. The message that's often missed is that surgery is needed for the treatment of many of these NCDs. Next slide. The scale of the problem that we face is enormous, with the annual surgical avertable deaths being more than 5 times that of HIV, TB, and malaria combined. And if you look at traumatic injury alone, that's more than double. Next slide. The momentum for change is building. And in 2015, it was a pivotal year for several reasons. WHA Resolution 68.15, strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage, was unanimously adopted by all member states. Then again last year in 2019 World Health Assembly, Resolution 72.16, emergency care systems for universal health coverage, ensuring timely care for the acutely ill and injured, was also passed, being proposed by Ethiopia and Eswatini, and co-sponsored by more than 30 countries. Dr. Terry Reynolds, one of our speakers today, worked tirelessly in moving that resolution forward, and we're really looking forward to hearing more about these resolutions in her presentation a little later. More happened in 2015, but now I'd like to turn it back over to you, John, to continue. And thank you very much. The floor is yours.
Thank you, Jeff. So in 2015, I also wanted to bring up something else that was somewhat of a milestone for global surgery. So this was the publication of the Lancet Commission on Global Surgery. Now, the commission did 4 things in particular. The first was it declared a vision for global surgery, universal access to safe, affordable surgical and anesthesia care when needed. It also came out with 5 key messages, 6 indicators for how we would track progress around the surgical ecosystem, and more apropos of today's session, came out with a concept of surgical strategic planning at a national level. Now, the first country that embarked on this journey with the Lancet Commission was Zambia. Emmanuel Makasa actually was part of the commission, and he led this in Zambia. And they changed the name slightly. They added obstetrics and anesthesia and called it a National Surgical Obstetric and Anesthesia Planning Process. And they looked at 6 different domains in their surgical system. And they came up with with goals and targets, and they costed this out. Now, what we saw after that is that a number of countries embarked on this journey, and you're going to hear more from several speakers today. So Dr. Samad from Pakistan and Dr. Wanganabete from the Pacific Islands, from Fiji. He'll talk about those countries' specific work in this area. We had a number of meetings along the way, and I wanted to show you a video from Dr. Tedros, because this was a meeting where we brought together a number of stakeholders in Dubai who were interested in this concept of national level planning around surgery. And he did just a wonderful job of summarizing everything. So I want to have you listen to what he said.
Lord William Itangi, Professor John Miara, Dr. Walt Johnson, Lord William Itangi, Professor John Miara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen, greetings from Geneva, and thank you for the invitation to speak to you today. And I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than $12 trillion. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
So I wanted to show you that because Dr. Tedros did a wonderful job summarizing the integration of surgical care into UHC and the SDGs. Now, between 2015 and the present, we saw a proliferation of countries who were interested in the concept of integrating surgery, obstetrics, anesthesia into national health planning priorities. So as I mentioned, Zambia and Ethiopia actually started along with them in 2017. By 2019, there were more countries that had embarked on this process. So Tanzania, Rwanda, Pakistan, Nigeria, and as I said, Dr. Samad will be speaking about the Pakistan experience. Something happened also in 2017, 2018, and 2019. We saw regions become interested in this. And so the South African Development Community in November of 2019 passed a resolution that all of the SADC countries should work towards having comprehensive surgical strategic planning as part of their national health planning priorities. And then we also have the Pacific Islands who have embarked on a process, and Dr. Wanga will talk about that later today. Also, the Western Pacific Regional Office of the WHO has made this a priority to the extent that even this year in the regional committee meeting, they passed a resolution, WPR RC 71.R2, safe and affordable surgery. And I just pulled the very end of the document just to show you that what they talk about in this resolution is, if you look at number 3, this requests that the regional director provides advocacy and technical support to member states to facilitate dialogue and exchange of knowledge, experience, and lessons and best practices among member states, and to report periodically on progress in implementing the action framework for safe and affordable surgery in the Western Pacific. So what started as an idea, a concept for integrating surgical systems into national health priorities, you see has expanded to a number of countries and then to regions. Now, I think the next concept, however, is when you look at surgical and emergency system strengthening, and we see these resolutions, and Jeff talked about those. Terry is going to give a little bit more detail on the resolutions that led up to both the surgery resolution and the emergency systems resolution. How do we go from those resolutions to implementation? And you're going to hear that from several of our speakers today. Now, when the Lancet Commission came out in 2015, the narrative was really around UHC and SDGs and surgical health system strengthening, and that's still certainly appropriate. However, for obvious reasons, there are some new concepts to deal with and some new narratives and thought processes around what is the role of surgery, for example, in the surgical ecosystem in pandemic preparedness and global health security. We've all seen what anesthesia, anesthesiologists, surgical infrastructure, ORs, recovery rooms, et cetera, how those were involved in this present pandemic. And also emergency systems and trauma surgery. So you've seen that there are 2 different resolutions for those, but really the Venn diagrams overlap quite a bit. So trauma surgery and emergency systems need to be very well integrated, and also emergency systems, trauma surgery, and the broader surgical ecosystem has to be integrated. So we'll talk a little bit about that. So in summary then, how do we integrate surgical system strengthening with emergency systems and trauma surgery? And then what does this mean vis-a-vis pandemic preparedness planning and global health security? All right, so I would like to introduce our next speaker, Dr. Jim Harrison. Jim is a trauma and orthopedic surgeon from the National Health Service at Chester in the United Kingdom. He's also the Africa Regional Director for the AO Alliance. He's the founding member of the Orthopedic Research Collaborative for Africa. The acronym is ORCA. Jim's going to be talking to us about essential components, surgery and trauma care as essential components of UHC. Jim?
Thank you very much, John, and thanks everybody for attending this session, which is so exciting and so important to us all. So I'm going to talk a little bit about the scale of the problem, which is in terms of global injury. I'm going to look at it compared to some other health issues, non-communicable and communicable diseases. I'll highlight some of the demographics of the particular problem that is in injury. And it isn't an accident that I've given you a picture of a child, could equally have been a young adult who's there with an injury. And I'm also going to talk a little bit about the potential solutions, these solutions which have been tested that can work, but which are not widely available to the majority of the world's population. So on conservative figures, injury kills about 4.6 million people every year. But the staggering thing is that of those 4.6 million, 4.1 million, that's 90% of them, are in low and lower middle income countries. They're in the poorer parts of the world. And 1.6 million of those are young people, mostly young adults, but also children. A lot of the deaths are related to road type trauma, but not all by any means, but 1.2 million deaths every year attributable to accidents and crashes on the roads. This is only the tip of the iceberg, because for every one that dies, at least 10 are left permanently disabled and many more temporarily disabled. And these people then have difficulties providing for their families and sustaining the economies of their nations. Again, if you look at that in terms of where those people are, we're talking about 41 million people who are newly permanently disabled every year in LMICs. The majority of those people have what we'd call musculoskeletal disabilities. That's to say the results of trauma to their limbs. And most of these could have been prevented or could have been far reduced with early access to appropriate care. So is this problem achieving the attention that it deserves? Well, I can give you a resounding no to that. And this is a very sad situation. So this is a chart showing the impact of different DALYs, disease-adjusted life years. So for an equal amount of burden of disease, this is the relative funding that's being put in at the present time. And you can see that for injury care, that red bubble is exceedingly small. If you go across to the orange bubble, that is HIV, you can see that it's 100-fold more funding for every unit of health need. And if you go right across over to the purple bubble that's representing mother and child health, then it's up to 1,000, in fact, more than 1,000-fold the investment in health currently for equal amounts of health need. These are all worthy needs, and it's not a case of saying that these other needs are not there to be supported, but there's a huge disproportion which is currently quite scandalous. And further than that, the problem in terms of accidents and injury and from injuries getting worse year on year, and the prediction is that by the year 2030, road traffic crashes alone will account for the 5th position in deaths. And as I say, a lot of injuries behind every death. If you look at what's predicted to be ahead of it, then it's particularly going to be 4 of the non-communicable diseases, but most of these are occurring in older people and many are lifestyle related. Here's a bit more detail on the fact that the injury burden is particularly hitting the most young and economically active and key people of the society. So if you're between the ages of 15 and 29, injury on the roads is the leading cause of death. And anywhere between the age of 5 and 44, death from road-related injury is somewhere in the top 3 risks of death for you. 90% of these, as I've said before, are in the poorest countries of the world. And even within those countries, it's the less privileged people that are suffering, because these are mainly pedestrians, cyclists, and motorcyclists, not the people who are privileged enough to drive a car. Car ownership's much greater in the high-income countries of the world, and there are about 30 times more cars per head of population in a high-income country than a low-income country. But despite this, the risk per 100,000 of population is almost 3 times as high in the low-income country. So there is a huge discrepancy here. So are there any solutions to all this? Well, yes, there are. Some of the injuries are severe, like the one that I'm showing you there, and no apologies for that. But there is the opportunity to treat these injuries, but the care needs to be timely, appropriate, and affordable. And appropriate's a big thing, particularly in the care of trauma, where there are many different ways to treat, which come in at different costs. But an open injury like this, and these are very common in the low-income countries, is subject to infection, gangrene, amputation, and in some cases death if it doesn't receive appropriate early care. So the care depends on access, and the access requires infrastructure, training and presence of health workers, and of course decentralization and processes that enable access and affordability. One of the beauties is that the same treatment of the injuries and trauma integrates perfectly with the broader subject of this panel in surgical diseases. The same people that provide anesthesia for a cesarean section or a laparotomy are perfectly placed to provide anesthesia to the injured person. And so many of the skills and many of the equipments and the physical infrastructure all overlap. So do the systems that bring people to the hospitals. So an integrated system is really the obvious solution. This picture was sent to me a week ago by my son, who works in the Democratic Republic of Congo. And this is one of the health centers that he supports. That operating room there, and you may not recognize it as an operating room, did 34 cesarean sections in it last month. And I'm not sure how many injured patients were also treated in the same room. I can't see an obvious anesthetic machine of any sort. There's barely any equipment. And you can see that the surgical lighting facility is improvised at best. I'm sure that none of us would want our wife or our relative to have their cesarean section in such a limited and potentially unsafe facility. As regards the processes required for the trauma care ecosystem, we normally look at this in terms of the pre-hospital care, and you might put before that prevention, but injuries will still occur. You then need pre-hospital care, hospital-based care, and of course, rehabilitation itself. The pre-hospital care and the hospital-based care do a huge amount to prevent deaths, but also to prevent disability, and then disability can be much further reduced with adequate rehabilitation-based care. And all these things are cost efficient in actually saving money, with many economies losing 5% of GDP to the cost of trauma on the nation. Thank you very much for your time, and I look forward to further discussion later. Thank you, John.
Jim, thank you very much for that. And keeping in that theme, we now have Dr. Terry Reynolds. Dr. Reynolds leads the Clinical Services and Systems Unit in the Department of Integrated Health Services at the World Health Organization. The Clinical Services and Systems Unit brings together for the first time WHO's work on integrated delivery channels. Prior to coming to the WHO, she was the professor and director of global health for the Department of Emergency Medicine at the University of California, San Francisco. Terry, welcome.
Thanks very much, John. So I want to add a couple things to this. There's very little that I have to add, to be honest with you, to a panel like this. And you're going to hear a lot about policymakers doing policy themselves. You're going to hear a lot about clinicians doing clinical work themselves, health service managers. So what I would like to focus on right now is a series of 6 concepts that relate to the way that you can link surgery and anesthesia care, the actual services that people need, to this higher level discourse of universal health coverage. And so I'm just going to go through those one by one, because I think that's probably what WHO can add to this. WHO has a way of being able to link countries' priorities and people's health needs to these higher level agendas. And at our best, I like to think that is kind of what we have to offer. So you've heard a lot about these resolutions. I'm not here to tell you about them or their details, because many of you know them very well. And for those of you who don't, it's easy enough to find out. Each of them demands certain things of member states and certain things of WHO. And what is interesting about them in this case, however, is the progression and the frame with which this same issue has been approached over time. So in 2007, the first one you see was called emergency care systems, but it was really focused on injury, on the capacity of health systems and health system components for time-sensitive care to respond to injury. After that, in 2011, there was a different framing, but with some of the same content. How do you take the disaster management capacities and strengthen those in such a way that your health system is more able to sustain shocks? This one, of course, has emerged again front and center. And then in 2015, specific surgical care content in that resolution. And then around the same time, the Sustainable Development Goals, the SDGs, are ratified. And that is also part of the mandate, and I'll show you that in a little bit more detail. And then most recently, as has already been mentioned, this emergency care systems for universal health coverage. So circling back to the same language of 2007, but this time with a framing that is different in two ways. One, the focus on time for all of the acutely ill and the acutely injured, and then the framing explicitly within universal health coverage. The reason I mention that is because we now have a new dominant narrative, right? Many things that are being expressed these days relative to health priorities are expressed in terms of COVID. Countries, when they try to plan, when they try to act, ministries are in a position of needing to deal fundamentally with COVID. So the first concept I want to talk about, this bridge concept, is systems, really. And in the COVID context, there's two things that I want to focus on. One is that one important part of the discourse and around COVID and the COVID response is the idea of maintaining essential health services. So for the first time in this emergency, WHO has a formal space, a Pillar 9, for essential health services and systems. And that emerged out of a lot of discussion and lessons learned over the years, but specifically with lessons learned during the Ebola epidemic, in which we found out very quickly that the secondary mortality, so the deaths that occurred due to health system collapse, rapidly outstripped the number of deaths that the pandemic itself, the epidemic itself, was responsible for. And so now we have an explicit strategy around maintaining essential health services. Now, I flagged this for this audience for there's two things that I think are really important about linking the COVID discussion to surgery. One is that in this guidance you see from June 2020, there are a series of strategic shifts that countries are asked to make and decisions that each country will have to face. Each country will do it in a different way, but these are decision branch points for strategic shifts. And each one of these has a consequence for surgical care. So it is one of the things that this framework can serve is to look at how each of these shifts would need to be made to ensure the continuity and availability of surgical care. The other thing that I want to flag, and I made a specific example out of this in the revised guidance in June of 2020, which is that many countries around the world, initially there was a suspension of surgical services for all the best reasons, to sort of limit transmission and to protect people, to save lives. Then it became clear as we move into something that is not yet early recovery, but is certainly something different, something like late pandemic, what you find is countries that previously had been managing their surgical burden are increasingly faced with an enormous backlog. And either it's happening now or it is something that needs to be strategically planned for as we move into transition beyond this pandemic. And the reason that is so important as a global health and a public health issue is that so many countries around the world were already facing an extraordinary surgical backlog. So for many high-income countries, this backlog is new and is a consequence of public health measures taken to protect people. But for many countries, they were already there to begin with, and the pandemic has only compounded the problem. The second thing I want to point out quickly, and a couple of people have already said this, is that we need to be very, very clear and very obvious in our language that your entry point can be injury, your entry point can be preparedness and response, but if you strengthen parts of an emergency care system, and for WHO, That term, emergency care, also includes time-sensitive surgery, early operative and critical care. Most people think about those things in terms of the Sustainable Development Goals relative to these two targets. However, no matter why you invest, you get all of this benefit. So you get this benefit across all of these goals. So I frame that is the system part. We need to think about this as the concrete investments that you make in mechanisms for strengthening surgical and anesthesia care also confer benefits across a wide range. And that doesn't necessarily mean that surgery itself is at the foundation of this. What it means, nobody's at the center and nobody's at the periphery. What it means is that we have a common set of foundational elements that deliver through channels of care. And I'll come back to that in a minute. So that's the system. The second concept I want to focus on that is absolutely key to universal health coverage is the idea of a national service package. Many of you have been involved in these, some of you might not have, and some of you may have never heard of them. But essentially, one of the key mechanisms, not the only one, but one of the key mechanisms for making progress towards universal health coverage is, and usually this is executed at the national level, sometimes at the subnational, but almost always at the national level. Countries identify a set of what are often called essential packages of health services, packages of essential health services, national packages of essential services. And WHO has created a tool called the Uhc Compendium to help support countries to execute this process in a systematic and rigorous evidence-based way. And this compendium will launch in its version 1 on UHC Day in December of this year. But I flagged this here for surgery because this idea of national health service packages, and I put up here an example from Afghanistan done last year, is a key mechanism for ensuring that these services are part of what is prioritized for public health funds. So usually countries use these packages as a way of defining what services they are going to prioritize for investment of public funds. That's not the only way that countries formulate them, but that is a very common way. So the idea of having explicit surgical procedures within these packages is key. And I mention this because in the compendium, what we've actually done is there is a systematic architecture that countries can progress through to make explicit decisions about every disease area. And within that, there are categories of the kinds of interventions that they might select from. And there is a specific category for surgical procedures. So as you go through each of these conditions, as you look at cardiovascular disease or at myocardial ischemia in particular, you can add the medical interventions and the surgical interventions. The same thing is true for injury, which is obviously dominated by the more procedural surgical interventions, but also for areas that might be more balanced between chemical therapeutic interventions and surgical therapeutic interventions. I want to flag just here, the reason this is so important, this process of service package development for universal health coverage, is because the use cases for these lists, fundamentally these are packages of services or lists of services. The use cases for these is quite extraordinary and powerful. They're used for two sides of the same coin, as I mentioned, entitlement. So what is the government going to pay for? But also in settings where a lot of service delivery is contracted through partners, and that in some cases, those are many of the humanitarian settings, but also others. These lists serve also as a foundation for contracting. They serve as a foundation for service planning, and within that, for both human and material resource planning. And then finally, they serve often as a mechanism for program reporting. So you take all of your services, say, that save lives, save children's lives, and that becomes part of what you report on for your child health package. Certainly your maternal health package, the linkages and the contribution of surgery is obvious. But also in less obvious ways, there are aspects of surgery that are within, say, the bundle of TB interventions. There are aspects that are within the bundle of HIV interventions, et cetera. So when you do, say, HIV, TB, malaria program reporting, you carry along these surgical interventions. So that is the package. That's the second concept. So the systems, the packages, and then just quality is a really frequent entry point these days, because universal health coverage, the way it is formulated in most conceptions, includes the need to ensure access for everyone to a set of high quality services with protection from financial ruin. So the quality becomes a key aspect of that. And I just want to point out here, you may be starting in something that is not explicitly linked to surgery, like a national quality policy or strategy, but we have a number of tools, all of the things that we use to actually make sure that good surgical care, that good emergency care, that good trauma care is delivered. Many of those are just the projection of quality principles onto the service delivery setting, and we need to be good at telling this story. These are a couple that many of you are extremely familiar with. These are quality tools. They also happen to be surgical tools or trauma care tools, but they are quality tools fundamentally. Similarly, as part of this quality agenda, data and the utilization of data to create a feedback loop so that you are oriented to what is actually happening, so that actions that are taken to improve outcomes can be the most efficient and the most effective. This is a picture of some of the WHO integrated registry for trauma, international registry for trauma and emergency care. This built on an old document, the Guidelines for Trauma Quality Improvement. We told countries they should be doing trauma quality improvement. They should have registries. But then many years later, we were actually able to provide them with a platform that is open access and free to countries for use. What you see here is the registry built around injury. The EQIP that is coming is the emergency quality improvement, where it is expanded beyond injury to all other conditions, and that includes many of the time-sensitive surgical conditions. And then finally, the operative case model that we've done some work with the process that the World Federation of Societies of Anesthesiologists and John's group also led, and Utstein, on revising the Lancet surgical indicators. And as an output of that, we began working together on this operative case module. So that is the data quality improvement realm and the impact. Finally, I put this here because injury is probably the most evaluated within this idea of systematic looking at quality process. But the data from low and middle income countries, the actual literature base that supports the impact of these interventions that we know work, is incredibly limited. So I put this review up because one of the striking things about it was how many countries did not have studies that demonstrated impact. So there's a huge amount of work to be done there. So that's the third concept, the quality improvement in data. The fourth, I just want to send a second on, which is training. The capacity building that allows you to achieve universal health coverage. So this is not as sexy as some of the big concepts that talk about shifting tectonic plates and health systems all at once. But when it comes down to it, there is always this last mile. There's what actually happens in the interaction between a provider and a person who needs help. And that job, despite the dissemination of educational resources over digital channels being better than it has ever been, there is still the need for high quality, open access clinical training materials. And that is something where there is less and less energy focused. And so I bring that up here. Now, one of the problems is that documents are out of date. They're not that effective pedagogically, and they're not that sexy. But I want to flag for you here a huge effort underway at WHO, the WHO Academy, because a couple of the resources I've mentioned, the basic emergency care, a mass casualty management course, and an emergency response course, are all part of the Academy's first wave of courses that are being developed and will be launched at World Health Assembly next year in May. And strategically, our program plan is to apply then next for the Academy to update it in an innovative way, these key clinical resources, these WHO surgical care at the district hospital, the anesthesia care at the district hospital. And I just want to give those some attention as well, because they sometimes seem small, but that interaction at the service delivery level is what is going to have the most proximal impact. And AO is an extraordinary force in this area, and they have remained committed throughout and across decades to this, this level of direct investment in provider skills. The fifth concept, investment, we really need to be formulating this, as several of you have, so I won't spend a lot of time on this, as in an investment. And this is also this photograph, many thanks to AO, it comes from their team, from Claude Martin. So we need to formulate this as an investment. And I've seen, we have this Global Alliance for Care of the Injured advocacy slide deck that's available on our website. And I've seen a couple of you have used that, and that's great. And there are a number of different ways to frame this advocacy, but in particular, these micro investments. So sometimes you need to frame this as very small numbers. Sometimes you need to frame this as very big numbers. But to be heard, we really need to be doing both. That's the fifth concept, investment with impact. Now, the last one that I want to focus on for just a minute, because this is a key concept within universal health coverage, is the idea of integrated service delivery. Clinical services and systems is the unit that I had, and I put it up here specifically because it was a new unit that came out of WHO's transformation. And we have a few key goals. It creates something that hasn't happened in a while at WHO, bringing together these integrated channels of service delivery. So primary care, emergency care, surgical care, critical care, and then the content of palliative care that spreads across this. And you can imagine in any time why that might be a good idea. It allows you to look at things like service packages and organization of services and models of care, but also to look at pathways. So the actual journeys that people take across the health system and the pathways that we create for them by our service structure choices, our service organization choices. And that allows you to look at key conditions like injury, like sepsis, that require early recognition at the primary care level, timely intervention by emergency care, and then ultimately early access to surgical care. So this bringing these together allows us to look at the full arc, the way that actual people move across the health system. And then the clinical part of the name of the unit is a reinvestment in the renewal and updating in innovative ways of this clinical guidance. Now, this will be, I'm going to end here, but I want to mention this. Next month, the bulletin will have a special issue on what's called PHC, primary health care. And that is usually used to distinguish from primary care, which is the actual services that are delivered, to an actual strategy of the health system that is at a broader level, that has to do with the way that you plan, the way that you finance, the way that you create access channels for people. And within this, we have formulated an idea, and this is going to be a really key part of advocacy and framing where surgical and anesthesia services sit going forward. You can't have, and this was mentioned very early on, even just after, within a couple of years of Alma Ata, the role of hospital-based care to support effective primary care. However, then it was almost put up as a sort of straw man bad guy, the idea of hospital-driven financing as something that undermined primary care. And we finally have an opportunity to get around this false opposition and really formulate this. We're using this concept of an ecosystem slightly differently. I've heard a couple of people use the term, but differently than people have, to really mean as an acronym, really, for the emergency, the critical, and the operative care services that primary care requires to do its job well. And similarly, these services don't work. People can't come knock on the door of an ICU or an operating system. You need the primary care relationship at the center. So we use this term ecosystem to refer to these services, these emergency, critical, and operative services, but also the mechanisms that actually link them effectively to the people that need them. And finally, the last thing I'd like to say is just a shout out and a thanks to the AO Foundation. Some of you know about the Global Emergency and Trauma Care Initiative, which many of the activities that I've mentioned here are supported by AO as part of that Global Emergency and Trauma Care Initiative. Thank you very much.
Carrie, that was fantastic. You started out giving us a little overview of the resolutions. You talked about investments in surgery and trauma care and the fact that it's a holistic investment and it's a common integrated platform. I hope we have some time. I want to get back to some of the last things you talked about integrated service delivery and integrated packages, and hopefully we'll have time to get back to that. But now I'd like to introduce Professor Ali Jafarin. Dr. Jafarin is from Tehran. He's a hepatobiliary and liver transplantation surgery. He's the founding director of the liver transplantation program and the head of the division of hepatopancreatic biliary and liver transplant surgeon, or liver transplantation. He was then the dean of the medical school and then became vice chancellor at Tehran University Medical Sciences. He was then appointed as the chancellor of Tehran University Medical Sciences in September of 2013 for a term of 4 years. He finished up his term as chancellor, and he is now a member of the board of trustees of Tehran University Medical Sciences. So he has held leadership positions across the entire university, including his clinical career. So Dr. Jafarin, thank you very much for speaking with us from Tehran today. We look forward to your comments.
Thank you very much, John, and all the fellow panelists from my home on my 7th day of isolation because of COVID. But don't worry, I'm okay. And in my case, it was not severe, fortunately. Thank to WH's perfect guys in Berlin. And I missed them after 5 years being there in this meeting and now from our homes across the world. As you all know, we have faced with a very big crisis of COVID-19 now. And even in this crisis, surgery was one of the points that everybody had to take care of that. Because as all of us know, and Terry mentioned, WHO and many other organizations had some guidelines for the essential surgeries and treatments during this pandemic, which was at the first, not the first point, but when we came into it and we were faced with difficulties of patients who need essential cares, we found that surgery and essential treatments is one of the major points that we should take care of it. I'm going from the overview that panelists offered to us to a national level, giving an example to you from some aspects that John mentioned from at the beginning with the slide of workforce, service delivery infrastructure, finance, and governance. I want just to pick up the two and give an example of that from Iran, which was used to be a high middle income country, and now it is a low middle income country. And we've been faced with the same numbers because the trauma is the second cause of death, of premature death, and is the third or fourth cause of death totally in my country. So it is one of the major problems. And I want to start and share with you my slides on workforce, as you will see here now, what we have done for the workforce in Iran in the past 4 decades. I think that would be a good example of making the manpower and the workforce for the trauma surgery. I'm not going deep in the numbers because I want just to keep a whole holistic image for you. 40 years ago, we had about 10,000 teaching hospital beds, and now we have 60,000. And the faculty members in the universities of medical sciences, what about 3,000, and now it is more than 13,000. This is fourfold in this period of time. And when you go through the residency programs, we have made it more than 5-fold in these 4 decades. And when you see the number of the physician, the population per physician was something between 3,000 and now it is 655. We used to have, expatriate physicians and surgeons in our country, and most of the countrysides were served by the physicians from other countries with the, the trainings that was not so qualified, but there was a very severe lack of workforce. The work that has been done is that for instance, the general surgery training has been fourfold, both in respect to the residents per year. We have now more than 160 general surgery residents enrolling each year, and the faculty members is like, again, the fourfold, like 800 faculty members of general surgery around the country. And what we have done in the past 2 years, one of my a friend of mine who was an official of the Ministry of Health, they did a workforce planning for the future. This column, as you see, the first column, existent or available in 2019, is the specialties that we have right now. And the second is the needed for 2020-25. And the third is, if we don't intervene in any way, what we will be faced in the future in 2025. And as you see, the most deprived specialty is neurosurgery. So we will be in shortage. We are in shortage now, and we will be in shortage later on. For general surgery, it is in lower limit balance. For anesthesia, this is in upper limit balance. For OBGYN, it is in upper limit balance. And also for orthopedic, this is in lower limit balance. So this estimate for 2025 was based on all aspects of service delivery. That means educational, community hospitals, rural areas, and everything was integrated from different aspects. At least 3 studies were done from different offices in the Ministry of Health, and my friend of mine, Dr. Akbar Futuhi, merged all of this together and put this into a conclusion that you see here. What I want to mention specifically about the workforce is that we have a good experience of increasing the number of program and residencies, and we have a more just distribution of surgeons. In Iran, there is an obligatory service for all of the residency program graduates that they have to serve in the areas of where they are underserved for a period of time. The time depends on the area that the physicians goes there. If there is a very deprived area, they have to be there in a shorter time. And if it is better area, they have to be there. Usually it is between 1 and 3 years. And in this way, we have decreasing the difference from to the central cities of the provinces. So we have facilities, we have small hospitals in that areas that can serve people well. But the problem that we have and the challenges on the workforce, the first one is the quality control of the residency programs. It is a major issue that when you increase the number of residency programs in the country, you have to be shortcuts in the quality, and not always you can get the best quality that you want. The other issue is that delivering serving in these areas, the countryside areas, there are keeping the staffs there, anesthesists, surgeons, orthopedics, and everybody else who need to be there. The local hospitals is a problem. The other side is the life of those who are serving there. And that made a high turnover of specialists, especially for trauma and sexual surgeries in countrysides. The other issue is the effective payments method. If you pay too much, you will make them be there. If there is a fee for service, there may be an induced demand. And if you pay less, they don't work too much and they will refer the patients maybe to the central part. It is another problem which is somehow referred to finance and somehow referred to governance. And the other issue is the overproduction. When you produce enough workforce for the whole country and the people are not staying there for a long time, usually after a while, in my country, it may took 20 years, all of these educated and trained people are going to the central cities of the country. And again, you have to have another generation of surgeons and anesthesists for those local areas. I just want to add another measure that in my country has been successful in a good way, and it is the financing of the trauma patients. It is now more than 2 decades that all charges of and all costs of the trauma patients is covered by the Ministry of Health in a direct way. So it is not based on the insurances, and the Ministry of Health have a earmarked budget for the trauma care. So any patients who refer to any hospital around the country with a trauma case is treated, and the bill is going to the Ministry of Health. So even in the private sector. So the issue of getting the money for the service that the hospital is delivering to the patients is solved, and that makes all hospitals to do whatever they should do for trauma patients. And they are not, especially because some insurances, especially public insurances, have delay in their payments and covering the cost. So this is a problem that this is the solution for that problem, and all hospitals are okay with treating and delivering services to all trauma cases without any problem with the covering the costs. This is another way that make a governance somehow better. Maybe I have some points about the whole issue, and I will share with you later on. And now I will pass the panel to John and the other colleagues. Thank you.
Dr. Jafarin, thank you so much. We really appreciate that. And I'd love to come back to you at the end of all the formal comments and talk to you a little bit more about how you were so successful at expanding your surgical workforce and what type of planning went into that. Now I'd like to introduce Dr. Lupnis Samad. Dr. Samad is a consultant pediatric surgeon with a full-time appointment at Indus Hospital in Karachi, Pakistan. She joined Indus at its inception in 2007 and has served as the chair of the Indus Hospital Research Center from 2010 to 2016. Currently, she is the director of the Center on Essential Surgical and Acute Care at the Indus Health Network's Global Health Directorate. She is also a member of the Permanent Council of G4 Alliance and the Global Initiative for Children's Surgery. Dr. Samad, thank you for being with us today.
Thank you. Sorry for trying to organize myself a little bit as we started. I think I'm very glad I'm speaking after Dr. Reynolds has spoken earlier today, because this resonates so well with the concept that WHO is working on to integrate healthcare, first of all, and secondly, to work towards a UHC system. And that's really where we see strengthening surgical services in Pakistan as part of a health system strengthening exercise, which has to be integrated at all levels of care. So I think you're going to hear some of my practical experiences based on a lot of things that Terry has been talking about earlier today. Just for a quick recap on Pakistan, it is a country in South Asia. It's a large country geographically with a population of over 200 million. Interestingly, it has 4 provinces and 3 autonomous territories. Interesting because in about a decade ago, the several portfolios, including health, was devolved from the Federal Health Ministry and the federal government to the 4 provincial governments. So right now, the federal government looks after the health services provided in the Islamabad capital territory, some parts of the northern areas of Pakistan, but otherwise each provincial government looks after health matters and health implementation in their own provinces. That has a big say or role in the strategy that we've chosen to adopt in Pakistan, and I'll come to that in the next couple of slides. Also important for us to remember is that a large segment, up to 35% of Pakistan's population, is in the childhood age group, under 15. And therefore, we're looking at specific needs that need to be met for over 1/3 of the population. The Enso process, this is just a recap of a diagram that's part of the Lancet Commission that John has shown us repeatedly over the years, and that is really the basis. It's a schematic understanding of what the Enso process can involve. It's important to understand that this is not set in stone. It is a very adaptable process. It provides a format or a template for us newbies in the world of global health to start engaging with governments, to understand where to start, what needs to be done. In Pakistan, for example, because we started engaging with the federal ministry first, we got the ministerial support and ownership. We're working currently in the final steps of getting a baseline assessment for the country, and the stakeholder engagement has happened. But when it comes to implementation, we realized that we have to work with the provinces to implement. So therefore, as we navigated towards developing the national vision for surgical care in Pakistan, and this aligned well with Pakistan's existing national health vision, we realized that we need to focus on the federal ministry for the purposes of engagement, and then work with the provincial health departments to actually implement provincial plans. So we really worked with the program in global surgery and social change at the Harvard Medical School with huge support from Dr. Mehra. And then at the World Health Organization, we had Walt Johnson, who took a very active role in promoting this in Pakistan through WHO and through his personal efforts, really. And we combined with the Federal Ministry of Health and Indus Health Network, where I work, to put together this national initiative. And we couldn't even call it a plan, because a plan is what provincial governments were supposed to make. But we used the same framework to go through these steps. So we worked with the Ministry of National Health Services, Regulation and Coordination in Islamabad, a series of consultations, as a result of which at step 2, we were able to sign a letter of understanding with the ministry, notify a national steering committee, and create a technical working group, which had members from across the country, but also from PGSSC and WHO, who were able to help us put together the material that needed to be provided to enable the next steps. We had a national stakeholders conference in November 2018 with international and national participation, inviting professional society representatives from OBGYN, pediatric surgery, adult general surgery, neurosurgery, because neurotrauma is another area that understandably Walt Johnson and others in Pakistan were very keen to focus on as part of this initiative. And at the end of that conference, we had a consensus statement that gave a direction for surgical systems optimization in Pakistan. I think what's important for me to comment on here is that when we invited this broad base of surgeons, obstetricians and anesthetists from across the country, there were many people who were fascinated to understand that they could be a part of a global health agenda. They'd always really looked at themselves within the setting of ORs or at the most hospitals. But now they realized that they had a platform that could be utilized to engage in countrywide or region-wide surgical system challenges that everyone was facing. So that consensus statement really was a commitment on the behalf of stakeholders, including representatives from provincial governments and federal governments, donors, international NGOs, to work together to improve surgical services in the country. We created a draft, and last year in February, we conducted a series of provincial stakeholders engagement workshops. Now, this really was meant to jumpstart this process in each province, because that's, as I said, where the implementation had to take place, and get a broader engagement within each province to support this process. At the end of this engagement, we put together a detailed draft document, which is the National Vision for Surgical Care, which was then supposed to be presented to, approved by the Ministry of Health, Federal Ministry of Health, and signed off by all 4 provincial ministers as well. and finally integrated into the national health vision. However, this process has been delayed inordinately by changes in governments and ministers of health, which is one of the challenges that we have seen whenever we work in the policy arena. People change, and you just have to keep going back and pushing the agenda forward. And then the COVID has set everything back. This year's been a blank for many initiatives that were in the pipeline. And the eventual plan was then to finally develop provincial surgical obstetric anesthesia plans. So we've coined the term PSOPs as a derivative of NSOPs, and to work with provincial governments on the implementation. However, what we realized is that at the same time, there was a parallel process that had started in Islamabad, and that was the DCP3 pilot process and implementation at a national level. And we realized that this had a strong government support as a way of creating a universal health coverage benefits package, very much in line with what Dr. Reynolds has been talking about for the country. And so we decided that strategically, rather than create a parallel process in developing PSOPs, we were going to work with the DCP3 pilot project and integrate surgical services in the same framework. So just to tell you all a little bit more about this, this is the first of its kind in the world, where the Disease Control Priorities 3 network, the DCP3 network initiative, is working with WHO, the Pakistan's Federal Ministry of Health, and in turn all the provincial ministries as well, with technical expertise being shared by the London School of Hygiene and Tropical Medicine, specifically in the costing and prioritization exercises, and the health services unit at the Federal Ministry of Health, which is helping facilitate this project. The objective is to review the essential health services based on DCP3 evidence and recommendations to propose a universal health coverage benefits package for Pakistan. And this process involves burden of disease assessment relevant to Pakistan. A series of consultative workshops were held in 2018 and 2019, just about in parallel with the process that we were taking through in Islamabad at the NVSC. A costing exercise was developed. The UHC benefits package discourse was held in February 2020 to prepare a pilot of the PHC packages. Now, obviously, following February 2020, things went a little haywire. This process has also been paused temporarily, but in the past month, it's been revived with the pilot implementation now starting in the Islamabad Capital Territory. And we're trying to work with the stakeholders to see if we can implement this at 2 sites in Pakistan, one in the province of Sindh, another in the province of Punjab, to demonstrate the ability of this process to work in its practical form, and also to use that as a way of adapting the package as we go along. So it's a very dynamic process and in no way set in stone. I think it's important for me to acknowledge here that just starting the Enso process at the government put us on the radar of our own Federal Ministry of Health, because they'd started the process. And when I went and talked to them about this, is, oh my God, our DCP3 pilot doesn't have any surgeons on it, and 44 procedures of it are under the surgical umbrella. So there's no one to advise us on the National Advisory Council on that. So we said, we're here. And that really served as a great entry point for us into the process. Just looking at a little bit of a detail in this slide and the next, that the DCP3 talks about 3 care levels in addition to community and population based. So 3 service delivery care levels, which is primary, first level, and tertiary. And I think what, again, I'm just, going back to what Terry said, the importance of not excluding surgery at the primary level. Although some surgical interventions can be done at the primary level, it is important to note that all surgical conditions that are of a high priority in a given setting or country need to be recognized, stabilized, and then transferred. So I think the role of the primary healthcare system in early identification, correct recognition, and appropriate transfer, be it trauma, be it a gut perforation, that has to be integrated at the primary level. And we cannot just focus on secondary and tertiary levels for this surgical package. At the first level, there are some of these 46 procedures that are recommended, and 9 are designated to the tertiary level. Again, in the original DCP-3 recommendations, there were general surgical procedures, a total of 46, of which 42 are adult and 4 are in children. This includes things like cleft lip and palate, Hirschsprung's disease, and colorectal, anorectal malformations. But then what we did for the first time is create addendums for 19 conditions which required a pediatric surgical intervention, both in terms of expertise and different resource requirements. For example, a NICU requirement for children was imperative if you were looking at neonatal laparotomies. And a neonatal laparotomy cannot be done at a first level hospital in most cases, as opposed to an adult laparotomy or an adult appendectomy that can be done in the first level. So we created that distinction for the first time in making childhood age-specific addendums for these conditions. And finally, I think it's important to understand, and for us always to keep remembering, that surgery is not a silo. It is cross-cutting. It has a role in the MNCH arena, in the NCD and injury prevention arena, and it is mainly based in the NCD cluster. But oncological procedures, for example, are part of the cancer services improvement that we're working on. We have C-section, which is a surgical procedure. We keep forgetting that. And that is the commonest procedure that is being done in most countries, including Pakistan. And then when we talk about surgery, we are looking at a wide variety of surgical specialties that need to be involved. For the first level, it is not possible to have a general surgeon, an orthopedic surgeon, an obstetrician, and an anesthetist, along with a pediatric surgeon available. So what we're trying to work out in Pakistan is to see if we can use this cluster of surgeries that need to be done at the first level to create an equivalent of what India is talking about in terms of a rural surgeon, or a surgical equivalent of a family physician who can cater to a broad, less specialized group of surgical procedures that can be delivered at the first level with a better utilization of human resource. I think the important thing to realize is that collaborative efforts work. So this is when we were in Islamabad launching the National Vision for Surgical Care. With John was over there, a number of his team from all over the world, and our team from Pakistan have made it possible. So what I've learned really through the National Vision for Surgical Care in Pakistan and the Enso implementation in Pakistan is that innovate all the time. It's very important not to stick to a rule book. The Enso process is not a rule book. It's a great way of understanding what are the components that need to be considered, juggle around, adapt to your local needs, and rely on teams and expertise from those who've done it before. So as always, it's absolutely fantastic to be at a forum where so many people have done wonderful work in this area and to be able to add to that learning. Thank you so much.
Lubna, thank you so much. I love that presentation because what you did, and you summarized at the end, is you showed that the acronym ENSOP is not what's important. It's the process that you went through. And it was multi-stakeholder, it was national, it was provincial, it was DCP-3. And I think that's just a beautiful example, and that your process is going to be different than the Pacific Islands process. And next, speaking of the Pacific Islands, we have His Excellency Dr. Efremi Wanganabete. And Dr. Wanga, he deserves a special medal actually, because I think it's 4 or 5 in the morning there, and he's been waiting patiently since about 2:30 or 3 when we first started, before this session actually started. So Dr. Wong, I really appreciate you being here, and I just want to tell everyone a little bit about you, if you'll allow me. So, he is the Fiji Minister of Health and Medical Services, and he has been a surgical leader in Fiji for years. Did some of his original training in New Zealand, and won awards during his training. Won the Rowan Nix Fellowship and Scholarship, whereby he assumed the senior registrar position in New Zealand. Then went back to New Zealand and was a clinical leader there. And as I said, more recently has become the Minister of Health. And one of the things that I love at the end of his bio here is that he said he is a passionate advocate for equality, whereby he fervently believes that everybody must be treated equally regardless of ethnicity, gender, or religious affiliation. Honesty and compassion are values which he desires that everyone in the Ministry of Health and Medical Services will embrace so that everyone can cultivate a culture of high work ethic and professionalism. So with that wonderful leadership at your ministry, I'm looking forward to hearing your talk about your leadership in the national surgical planning process for not only Fiji, but all of the Pacific Islands. So thank you very much.
Thank you, John, and I would like to congratulate everyone who's participated so far, and talking is so interesting just to be able to hear what's happening from around the world. And good morning from Fiji. It's about 4 o'clock, just after 4 o'clock here. I just want to quickly just touch on our COVID update very briefly, because there's a lot of learnings from there that we've extrapolated and put through into our surgical strengthening. The important things that we've learned so far is there is an internal threat and there's an external threat. And we need to make sure that we have early warning systems in place for our communicable disease, and increasing our capacity for fixed and mobile sites. And also as an external threat, we want to also make sure that we have a strong border health unit and repurposing our incident management team to deal with our economic recovery efforts. And as I speak, John, there is a team up in the Highlands providing essential surgery for a week for basically elective surgery, while there's another team on the hospital ship based in the islands. We have about 300 islands and 100 of them are inhabited. So again, quite a lot of my slides, and I want to thank John and your team at Harvard for the great work that you've done, and quite a lot of my slides have come through from that Lancet Commission. But really, we just need to, again, understand the challenge that we have. We know that there's 5 billion people who lack access. About nearly now 145 million procedures are needed yearly to fill that unmet need. And 33 million face catastrophic expense after surgical care. We also understand that surgery is an indivisible, indispensable part of healthcare. And when we had the WHO Western Pacific Regional Committee meeting, one thing that I said in that meeting, and which I and the others have been championing about putting safe and affordable surgery, anesthesia, and obstetrics into the regional committee meeting, is that safe and affordable surgery, anesthesia and obstetrics, or essential surgery, is a public health issue of enormous capacity that we need to deal with. And I would like to actually say crisis, but we are in the middle of a COVID crisis, so I couldn't say crisis. But I think it's important for everybody in the public health space and in the global health space to understand that surgery, essential surgery, is also a very important public health crisis, so as to speak. Again, just touching briefly on Fiji's numbers are there. We have about 67% of the population within access to a bellwether-capable community, bellwether-capable hospital. And again, 5.8 per 100,000 is our SAO density workforce, and 1,490 procedures per 100,000 of the population. Perioperative mortality is 0.83, and we still have about 20% of the population that need to be protected from impoverishment, from out-of-pocket payments, and also from catastrophic expenditure. Again, these are slides taken out of the your work, John, and the group. And again, thank the Lancet Commission for this. But I think what is important to understand is that there's a now and a lot of work beginning to happen with ENSOPs right around the world, or even if it's not particularly ENSOP, planning around surgical planning around that same sort of thinking because of the advocacy that's happened on the global stage. And I totally agree. We all need to push. We all need to push at the highest level. We have to be very strong about it. We have to understand that as a group that is very interested in making sure that this is an essential part of universal health coverage, that we will never shy away from this. And it's actually nice to see those countries that have actually are interested, have launched, or in the progress of the ENSOPs. What is happening in the Western Pacific? Back in 2017, the Royal Australian College of Surgeons, which works predominantly with us in the Pacific. I am currently the president of the Pacific Island Surgeons Association. We came together and there was a Lancet indicator collection in the Pacific. Glenn Guest, who had worked in East Timor, actually put the paper together. As you also are aware that last year we had the World Health Assembly, we had the side events in surgery in small and developing states. We, the Pacific Island health ministers in our meeting, made a commitment to ENSOPs. And I was the previous executive board member of WHO from the Western Pacific region with the seat so-called allocated to the Pacific. And then our Fiji's turn was completed last year. And the next one on was Tonga. And we all said whoever's going to sit on that executive board will continue to push on the topic of safe and affordable surgery. And I think that is, John, if I may, that is our Pacific's commitment to this, is that at every meeting of the executive board, of the World Health Assembly, at the regional committee meeting of WHO with the Pacific, we will champion the progress towards safe and affordable surgery and essential surgery. And again, as has been alluded to, there was that regional action framework that was adopted by the regional committee this year. And I'm very hopeful that as the years begin, that we'll be able to then take it again to the World Health Assembly. And my dream is that it will be an agenda on the World Health Assembly, a standing agenda. In the ENSOPs in the Pacific, those are the countries represented that have actually had support from the Harvard Medical School and also from Royal Australian College of Surgeons and putting together the ENSOPs. And I have alluded to about Fiji's report. Again, the same framework that has been discussed. And we all know what the global surgical indicators are. And I'll just touch very briefly on what we are beginning to see in the Pacific. So we collected data data was collected from 14 countries. And you can see the green other countries that participated in this, and you can see Australia, New Zealand, Cook Islands, they were able to reach bellwether capable capacity within but as on the other side, on the blue side, some of the bigger islands in the Pacific, for example, Solomon Islands and Vanuatu and Fiji have yet to be able to reach that. And then looking at the SAOs right across the region, of interest, you can see the numbers are very big in the very small islands with very small populations, and if we look again at the big islands, like small big groupings like Papua New Guinea, Solomons, again down to Vanuatu and to Fiji, the numbers are maybe it looks smaller. And the global comparison. You can see what's happening in the Pacific is similar to what's happening in other undeveloped nations around the world in terms of the density of SAOs. Again, looking at volume of surgical procedures, you can see Australia and New Zealand, it's well above 5,000. And again, in the Pacific, quite a lot of the countries are not able to cross that threshold as of yet. And the same thing we're also seeing in the global comparison. The challenges that we are facing in the Pacific is again being faced in other countries that have the same GDP per capita, so as to speak. The perioperative mortality, I thought this was actually very good to be able to actually be able to do this and actually come up with our perioperative mortality rates. And it was good to actually see the numbers being reflected. Certainly there's quite a lot of work that needs to be done. And that's why, as I've said earlier, we the Pacific are very interested in actually continuing to advocate for this topic. And I've talked about Fiji's risk, but overall, as we know, the global average is about 44%. But you can see that there are countries in the Pacific that are well above that. And again, talks about the challenges that we have in the Pacific. So if we look at the Lancet Global Surgical Indicators, the first 4 indicators summarized, those that are there. Again, do not want to go into much detail, but suffice to say that you know, there is extensive challenges that are there in the Pacific. Our geographical location, the fact that there are countries with many islands, and again, some of these islands are difficult to access, makes it a challenge, and that's why you know, this topic is something that we really are very passionate about. And also the surgical indicators 5 and 6, and looking at the risk of catastrophic expenditure. John, I'll just go straight here. I think if we put it all together, I just want beginning to summarize what I'm talking about here today. There is opportunities for regional collaboration, and that's one thing that we in the Pacific do very well. We collaborate very well, and we've come together very strongly about this topic. And we know that working with our development partners and also the South Pacific Commission, we can be able to, you know, find ways to be able to plan ourselves and support one another. There are surgeons that have been trained in Fiji that are working in other countries in the Pacific. That's surgeons trained in Papua New Guinea that are working in other countries in the Pacific. So we're beginning to share our human resource capacity. We're also beginning to share not only the surgical capacity, but also the other HR important groupings that are important for surgical care. For example, nurses from Fiji, Papua New Guinea, other places are being able to go around the Pacific, anesthetists, biomedical technician. So there is many opportunities for regional collaboration. Alignment also to the universal health coverage, sustainable development goals, and one of the biggest challenges that we have in the Pacific is also non-communicable disease. And a lot of this non-communicable disease actually requires safe surgery. You know, the treatment of diabetic sepsis is something that the Pacific has a challenge with. We also are very disaster prone. And it is so important for us to ensure that we have preparedness not only from a natural disaster, but also from pandemic disaster. Things grow well in the Pacific. So you can imagine also virus and bacteria, they will grow well in the Pacific. Last year, Fiji, our emergency medical team became the 9th country in the world, the first small island development state to be certified by WHO. We feel that it is something that is essential for the whole of the Pacific. And again, the other Pacific Island nations are looking to us to be able to provide them expertise as they're looking towards having their EMTs also certified. The challenges are geographical isolation, small country populations, the specialized workforce limitations. We've lost a lot of people over the years to our immediate neighbors, Australia, New Zealand, and also to other places around the world, even to the United States and Europe, and also the limited access to markets. Because we are small island countries, in terms of economies of scale, we often struggle with sometimes with access to consumables and equipment because of the economies of scale. And this COVID pandemic that we've all faced brought a challenge right across the Pacific. And from Fiji's perspective, we're looking at actually making sure that we stockpile on whatever we have so that we can be at a better place to be able to manage our resources well, and also push out with our universal health coverage. What we've done in Fiji is, as I've alluded to, we've developed Enso. And again, I thank John, I thank your group for that support. We have just put out an expression of interest to appoint a national coordinator for safe and affordable surgery, obstetrics and anesthesia. We've also included it into our national health strategy plan, similar to what I've been hearing from Pakistan this morning, Fiji time. And that will look at development and improvement of infrastructure, information system, patient safety, and safeguards against environmental threats. We've aligned it to our annual operation plan, and also we've aligned it to the regional framework on safe and affordable surgery that was agreed on by the regional committee of WHO. We continue to support, as a government, we support the ongoing professional training, formal training, continuous professional development. We allow our surgeons, obstetricians, anesthetists, and other specialists, once they finish their postgraduate training, to go across to Australia, New Zealand, and other countries for further exposure. And I was a beneficiary of that. And recently, within the last few years, we've had a very significant salary increases for our doctors and health staff. And for the doctors, some of them double their salaries. And this has been able to stop the attrition rate for our doctors and our specialists who have had significant training both locally and abroad. What we want to do is we've started on remodeling of our health service. And really our remodeling that we've done is actually to accelerate our pursuing universal health coverage. We have 210 facilities, and we believe that that all these 210 facilities are point of contacts for surgical care, not necessarily surgical operations, but for surgical care. We've also just begun remodeling our procurement and supply chain for medicines and consumables to ensure that we are not compromised because of the economies of scale. On that note, we've also joined with 6 other countries so that we can actually look at a way we can bulk purchase. As I've alluded to, our emergency medical team has been WHO certified, and they are leading the surgical outreach programs right throughout the country. And we have a hospital ship that we got 2 years ago. That has 2 theaters and 10 beds, and has capacity for about 50 staff. So that goes around the islands, providing surgical outreach to our maritime communities. And we want to continue to do that in our maritime communities. With capacity development, we are beginning to collaborate with external partners. And I think this is the essence of what I want to talk about today. We cannot do it alone. Small island development states cannot do it alone. Undeveloped and developed countries cannot do it alone. It has to have support from development partners. And that, John, is the essence of actually pushing it onto the global agenda and keeping it on the global agenda. Because development partner support and expertise is needed to be able to accelerate the growth of essential and safe surgery for small countries. And really, as a nation, we want to keep on collaborating, because one target that I've put across to us is to say, look, I do not know of any country in the world which is a WHO collaborating center for safe and affordable surgery. Let's try and do that. I know it's a big ask, but I know it's also an opportunity to be able to really champion this cause. Next. Thank you, John, and thank you to all the other participants. And I'm sorry if I'm not coming out well. I'm a bit sleepy on this side, but thank you.
That was wonderful, Minister Wonga. That was not sleepy at all. That was fantastic. That was a tour de force showing what your leadership has done both in Fiji and the Pacific Islands. And I'm so happy, and it was nice how you end on the concept of collaboration. That's just a wonderful message. Well, it looks like we did not have a hard stop at 12:30, although I want to respect people's time. So if we can maybe get a few questions in before they end the session, I'd like to give it a shot. So I'd like to start back at the beginning. And Jim, I want to thank you again, and I also want to thank the AO Foundation, because the AO Foundation helped support this session. So that was very kind of you and the foundation. You know, I was looking at one of your slides, it was slide 11, and it was towards the end where you had the trauma care ecosystem. And it was a beautiful slide that talked about pre-hospital, hospital-based care, rehab. And you talked about how the foundation's involved in education, research, fellowships, and infrastructure. And I was thinking, you know, is there room for the AO Foundation to be involved with countries, whether it's, you know, Fiji or Pakistan, who say, gee, we're embarking on this process of, you know, surgical strategic planning, which ought to include trauma surgery, et cetera. And if then you include emergency systems, is that something that the AO Foundation could be involved in working with the country through that process?
Yeah, thanks very much, John. Yes, certainly. So just for a bit of clarification, there's the AO Foundation, the AO Alliance Foundation. I'm representing the AO Alliance Foundation, and we are actually a separate entity, but we've come out with the blessing of the AO Foundation so that we can particularly focus on the poorer countries of the world, the low-income countries and lower middle-income countries. So AO Alliance for those countries, AO Foundation for the high income and the more mainstay middle-income countries. In both organizations, there is a capacity and an interest in supporting countries who want to develop a national trauma plan, and indeed to integrate that into a national strategy on surgical, obstetric and anesthetic care. So yes, we have done that before with countries. We supported Myanmar in making a national trauma plan. And then we've been doing some fracture care initiatives in other countries, Malawi, supporting Ethiopia, which already actually had its own plan, but we've been able to work with that in Ghana also. So yes, we'd be pleased to have approaches from the AO Alliance point of view from the low and lower middle income countries.
Thank you, Jim. And let me formally thank the AO Alliance then, to be perfectly proper. Dr. Jafarin, I was fascinated to see how the numbers of your workforce increased so rapidly. What kind of a process went into that? How did that happen?
The major issue that made this happening was that we have an integrated Ministry of Health and Medical Education from 30 years ago. So all of the hospitals are related to the Ministry of Health, and also the medical universities are working with the Ministry of Health. So the education in the medical services, all of the medical services, including medicine, dentistry, pharmacy, everything else, nursing, midwifery, and everything else, is under the Ministry of Health. That was a rapidly expanding infrastructures for education. So I'm not totally agree with all of the consequences of that, but what has happened is that with this integration of services and education, we have more than doubled the teaching beds around the country, and then the faculty of medicine were increased to maybe sixfold in 30 years, and so we have this expanded capacity for that.
Excellent, thank you. Dr. Reynolds, your discussion about integrated packages, I think, is really very important, and I know, I have a feeling one of my PGSSC folks is going to come up and ask me, well, integrated packages versus DCP 344 surgical, like are those different, the same? How do they work together? If a country is working with DCP the way Pakistan is, how does that mesh with the integrated WHO packages?
Sure, thanks, John. I should be quite clear, there is no particular WHO package. We work very closely with DCP also, but countries around the world are undertaking processes of developing national packages. Sometimes they're called service packages, sometimes benefit packages, same thing, just, yeah. The DCP is a really high quality source of interventions that one might or might not choose to include in a given national package. The UHC Compendium is a kind of suite of tools. It is in part a database full of all systematic architecture that looks at all of the categories in which a country might choose to put services so that you don't miss any. So it leads them through a systematic approach. And then also includes a service selection interface, allowing them to kind of click onto services that they might choose and to assign that service to a given level of the health system. And there's a number of reasons why you would do that. You want your lower level services that say refer. You want someone to catch the ball at higher level service. You don't want to be referring here for a time sensitive surgical procedure if that time sensitive surgical procedure is not assigned to the higher level. So DCP is a source of possible interventions. And then the DCP team has also done a lot of translational work with a kind of content to policy approach. So they have supported several countries, but neither DCP or WHO is really exactly developing its own national package, right? These are tools to help countries develop national packages. And the key aspect to them is there are a number of different criteria that countries use to choose services, but effectiveness and cost effectiveness are very high among those. There are a lot of other considerations, though, ethical considerations, et cetera. So these are tools to support countries once they've chosen the criteria. These are tools to support the process of selecting services. So
that's perfect. That is perfect, and it leads right into my question to Dr. Samad. So my suspicion is that since the National Surgical Vision process and the Enso process that you had gone through doesn't really have a package component to it. It is really just a thought process, if you will. How hard was it to then incorporate the DCP3 packages, or was that not a huge issue? Because in one sense you think, gee, you're going down one path, and is it a complete switch, or was it just a matter of incorporation and not completely redoing everything?
Well, I think it's very important to realize that the ENSOP is a policy process. It defines an engagement method, whereas, and it's a great, as I said, it's a great way for us to navigate bureaucracy and governments when many of us surgeons don't know where to start. But it in no way defines or delineates or gives a set agenda for a country or a region to follow. So even as you're talking about the SADC countries, within that region, different countries may adopt completely different approaches, but each one of those approaches has to zero back into stakeholder engagement, understanding what your baseline data is, governance methodology. How you do it is different. Your steps may not be 1, 2, 3, 4, 5, 8. It may be a jumble of those sequences. Also, the Enso process in no way dictates what the surgical procedures should be. So that really is, as we've all been talking about, as it has to be locally adapted, locally customized, because that's the only way any process will succeed. I think the important thing to recognize is the flexibility that the approach allows you. And I don't think countries should be daunted by saying we've got to get a set menu. It's really cook as you go along. This is just the ingredients that you need.
That's a great, I think that's perfect, and that's how it should be. Minister Wanga, I've been so impressed with how you've galvanized that whole region, and I wish I could kind of bottle that up and bring it over to my part of the world here. But what's next for you? You mentioned that there are 5 countries that are embarking on this process, and so I know there's a greater community of ministers in the Pacific. So what's the next step? Vis-a-vis your surgery efforts.
Yeah, what we have to understand is that it is important to talk about this in every discussion around health. So when there is a COVID discussion, is to put this into the agenda. When there's a discussion around, for example, immunization in the Pacific, we have to find its relevance in every health discussion. That's the only way in which we can keep this alive, keep it afloat, and keep it at the forefront. Because interestingly, just to share a little bit, as you know, I'm a surgeon. Our permanent secretary is an obstetrician. Our chief medical advisor is an orthopedic surgeon. And we've just managed to somehow become one of, a COVID-contained country for quite a long time. And none of us had been in the public health space. So you can actually realize that we surgeons have the capability to punch well above our weight in the public health space. The only problem is that the spaces that we've been punching in is actually different from where our public health partners have been in. We need to get into that space. And one thing that I've seen that our public health colleagues do very well is that they use every platform to be able to raise awareness on the issues that they are very passionate about. Whereas for us as surgeons, we raise awareness at a surgical conference where we meet other surgeons. And this is the first, the last 10 years has been the awakening for us, is that we need to be in the global space. And I know there's our WHO counterparts are listening here, and they will completely agree, is that this is the spaces that we need to do. So as you always were, your question was what we need to keep on doing is, and the answer is very simple. In every discussion around health, whether it be the Pacific region or any other region in the world, we need to find a reason to be there. We need to find a reason to talk about the importance of essential surgery. That I think is the key.
Great message, a message of integration and rolling up your sleeves and being there and discussing the issues when prioritization is being undertaken. We could go for another hour, and I appreciate everyone's patience. We've run over a tiny bit, and I want to be respectful of everyone's time. So number one, I want to thank the World Health Summit. This is the first time that they've had a session on surgery, and we're beginning planning hopefully for next year. And so hopefully we will reconvene, hopefully in person. So I want to thank World Health Summit. And again, I want to thank the AO Alliance for helping to support this, and all of our speakers today. Thank you very much for giving up your time. And Wanga, again, thank you for being up in the middle of the night. That was fantastic. Jeff, also, thank you very much for co-moderating with me and for supporting from the Global Surgery Foundation. So this brings our session to a close. Thank you all very much.
Thank you, John.
Thank you.